was asked to come to Washington to do a presentation on prevention. As I worked on the presentation, I titled it, "Is Prevention a Moral Obligation?" If any of you have worked with the federal agencies before, you know that you have to have your presentation vetted. And so I sent the presentation ahead of time. They reviewed it, gave it an A-OK, except they said I could not use the word moral. And so I had to change the title of the presentation to "Is Prevention an Ethical Obligation?" I didn't think much more about that until I began preparing the presentation, updating it, preparing a lot of new information for today's webinar. And I was curious as to the difference between moral and ethical. And so I did what my granddaughters have taught me to do. I went to Google. And what I found is there is a difference. Moral is defined as concerned with the principles or rules of right conduct. So that's on a very personal level, it seems to me. Whereas ethical is defined as being in accordance with the rules or standards for right conduct or practice, especially the standards of a profession. And I realized that ethical really looks at behaviors within systems and in relationships through practice. And so what I'm going to do today is focus first on the ethical, looking at how we develop standards for practice, standards of care for systems, and then from there segue into the personal responsibilities for moral practice. Now, ACOG, the American College of Obstetricians and Gynecologists, published a statement back in 2004. As part of a larger ethical statement, they said, quote, "Physicians have an ethical obligation to learn and use techniques for universal screening questions, brief intervention, and referral to treatment in order to provide patients and their families with medical care that is state-of-the-art, comprehensive, and effective." And if you look at that statement, it fits perfectly with our definition of ethical from a practice or systems perspective. So the next question is, where do we have opportunities for prevention? And when we have those opportunities, how do we develop policies that are in fact ethical? And I think 4 basic principles have to guide us in our development of ethical policy. The first is therapeutic intent. That is, what is the purpose of any policy that we develop? The second is do no harm. So I think that refers to, are we developing policies that are in the best interest of children and families? The third point is justice. Do any policies we develop ensure access to care, a fair distribution of resources, and do these policies address the racial and social class bias that exists in healthcare systems? And finally, respect for autonomy. That is, are we recognizing the rights of families to be able to receive care, to find care, to receive the kinds of services they need in the context of their family? So, based on those 4 basic principles, and now looking in the community as to where we can implement appropriate policy, this is the series of prevention touch points that I've developed for this webinar. They go from the preconceptional period, that is, how do we get information out to the public and to professionals that recognizes the risk of using alcohol and drugs, tobacco during pregnancy. And then within pregnancy, during the prenatal period and during labor and delivery, how do we identify those families at risk in a fair and ethical way, applying the 4 principles of ethical policies. And finally, in childhood, what are the systems that help us ensure that children have access to early intervention and other care they need? So let's go in order. We're going to start with the preconceptional period. And as an example of this, I'm going to ask the question, how do we communicate a public health message? We, in fact, did some research funded by the Federal Maternal Child Health Bureau several years ago, in which we asked that very question. And I'm going to talk about a very specific message development that we investigated. So what we did in this research was, first of all, develop a round of focus groups. And we had to decide what population were we targeting. And so we conducted focus groups in several communities around the country that consisted of women of childbearing age, adolescents, both boys and girls, and adults, both men and women, who were not pregnant at the time, but who were considering pregnancy. And these focus groups included men, women, adolescents, across multiple racial and ethnic populations. One of the issues that we talked about in these focus groups was the importance of data and the understanding that good policy is grounded in good science. And the key question then, coming out of these focus groups, was how do we state an effective prevention message? The specific point I'll talk about today is the federal statement with which I'm sure almost all of you are familiar. And that statement from the federal government says, there is no known safe amount of alcohol you can drink during pregnancy. Now, we presented that message to our focus groups, and let me mention it was studied in both English and Spanish. And we asked our focus groups of very diverse populations, we asked the participants, what does this message say to you? And the common response we got is, well, there is no known safe amount, but that means there probably is a safe amount. So drinking a little bit of alcohol during pregnancy is okay. We then took the word known out and studied this statement. There is no safe amount of alcohol you can drink during pregnancy. And the response we got again was, well, that means that probably there is some amount of alcohol you can drink. We then redesigned the statement using the same words but putting them in a different order and came up with this statement: no amount of alcohol is safe to drink during pregnancy. And the common response was, oh, you mean I can't drink anything? This just demonstrates that when we communicate with the public, we have to be very straightforward. We have to be very clear on what we want to say, what we want to communicate. And let me mention that some of the focus groups were performed with physicians and nurses. And their response was the same as the non-professional populations. The only message they really understood fully was this one: no amount of alcohol is safe to drink during pregnancy. So that's been the touchstone of much of our work. And if any of you, I know many of you use a lot of our materials, our brochures, our posters, and you'll see the common thread across all of our work is no amount of alcohol is safe. Now this, of course, can be used to communicate around opiates. No amount of any kind of narcotic is safe to drink during pregnancy. No amount of prescription drugs is safe to use during pregnancy. unless approved by your physician. So you can take this statement and use it in a variety of ways. Now, as an example, one of the groups we worked with was, and still work with, is a group in Mendocino County, California. And the question was, how do we reach the population they wanted to reach in Mendocino? And one of the first things we did was talk about what people would listen to. Now, we used this statement, of course, but also we looked at who holds the power, who holds the influence in the community. And one of the groups that was identified as being very influential in the community were the wineries, where winemaking is one of the primary sources of income in the county. Now, we had already done the study for the state of California, in which we showed that the rate of alcohol use during pregnancy is directly correlated with the number of wineries in a county. And so we thought this would be a good way to approach it. Now, the other question we had to ask is, where do we go? Where are the narrow gates in the community where our target population gathers? Is it in doctor's offices? Is it in community events? And what we realized in Mendocino County, one of the primary recreational activities in that county is the movies and the movie theaters. And so through the good work of the maternal child adolescent health team in Mendocino County, we recruited the wineries and we developed a statement and a graphic that then was shown at the movie theaters during the preamble to the movie. And as all of you know, when you go to the movies, you have to sit through several advertisements. But the poster and the message we came up with was this one: we don't want you to drink during pregnancy. And what we have is we have the families that own the 3 major wineries in Mendocino County. Now, the wineries bought into this because it's not saying we don't want you to drink. The wineries are just saying we don't want you to drink during pregnancy. And I hope you see here how this soft sell, but very pointed approach to communicating a message works. So moving out of the preconceptional period, we have to move to the prenatal period. Again, science has to be at the core of our efforts. So we have to ask first, what do we know from the science of substance use, and pregnancy? So here are the core ethical issues that we know that have been shown through science. First of all, women are different from men. Heavy drinking produces higher cardiac and liver damage risk for women than men. And this isn't just pregnant women, this is all women. And for all women, alcohol-associated death rates are 50 to 100 times higher than in men. Women are more likely to be hidden drinkers, and women are more likely to have physical and mental disabilities associated with alcohol use. And this includes higher rates of infectious diseases, such as HIV, hepatitis B and C, homelessness, domestic violence, and co-occurring mental health disorders, especially depression. So any message that we develop for women has to address the specific characteristics of women. What else do we know? In looking at professionals, studies have shown that physicians do treat women differently than they treat men. And unfortunately, this has been shown to be true for female physicians as well as male physicians. Women are less likely than men to be screened for substance use problems or referred for therapy. And in general, women are viewed as more hopeless if they're using drugs or alcohol than are men. And then just a core base of knowledge about substance use and pregnancy is lacking among healthcare professionals. Now, I keep mentioning physicians because that's the group that these studies have been done with. I do not have data for nurses. But among obstetricians, for example, at the time these studies were done, and this comes from about 10 years ago, 25% of obstetricians screened for substance use. Now, we think this rate has probably gone up, especially since the passage of the Affordable Care Act, but we really don't have any further data on this. And at the time the study was done, 80% of obstetricians said alcohol use during pregnancy is okay. Now, when asked specifically about how much alcohol, physicians responded that light drinking was okay, but then light drinking was defined in this study as an average of 1.2 drinks per day. So that's a drink of alcohol 7 days a week. And then the great majority of physicians stated that they did not have any knowledge of referral resources. And then what else do we know? We know that treatment works. Interestingly, the rate of abstinence from drugs of abuse, including alcohol, is the same as getting a diabetic or someone with hypertension to comply with treatment. The rates are the same. We also know that although treatment is best, brief interventions within the primary care health setting have been shown to be just as effective as traditional treatment modalities. We also know that interventions in prenatal care reduce rates of low birth weight, prematurity, required ventilation, and in the general treatment community, not just pregnant women, but in general, treatment for addictions saves $7 for every dollar spent. If you translate that to the general pregnancy population, it's been calculated that you get about $4,644 in savings for each maternal and neonatal dyad. And then next, I'd like to go a little bit further into what we know about intervention in pregnancy and its impact on maternal and child outcome. The first study specifically of this issue was one that we conducted back in 1989. It was a relatively small study of 75 pregnant women, all of whom were active cocaine users, and they entered their treatment into our treatment program because of their cocaine use. But as all of you understand and are aware of, polydrug use rates are extremely high in this population. And over 90% of the women who entered treatment with us, although they listed cocaine as their primary substance of abuse, 90% of them were using other drugs, especially alcohol. All of the women that we entered into this study came into outpatient treatment in the first trimester of pregnancy, and we ended up with 3 groups. Now, mind you, this was not a randomized study. You cannot randomize women and say, okay, you have to stop using drugs, you can continue. So we had to do it a little bit differently. All the women entered in first trimester using. 23 of the women were using drugs when they entered treatment with us, but by the beginning of the second trimester and throughout the rest of the pregnancy, they used no further drugs or alcohol. So they reached abstinence. The second population were those women who entered in first trimester who were using drugs and alcohol, and although they were in treatment with us, they continued to use. Now, I will mention that these women, although they continued to use, their rates and doses of drugs they were using did decrease. And then the third group were the non-using women. This was a group of control women matched for race, ethnicity, age, gravidity, all the socioeconomics, all the other factors that you have to match for when you do this kind of study. Now, what we found in this study, this first study, was that when we compared those women who used drugs and alcohol only in the first trimester and compared them to women who used all 3 trimesters and compared both groups to the drug-free women throughout pregnancy, the rates of preterm delivery were significantly lower in the women who used only in the first trimester as compared to 3 trimester use, 17% versus 31%. When it came to low birth weight babies, none of the babies born to mothers who stopped their use by second trimester were low birth weight or small for gestation age, whereas 25% and 19% respectively of the women who used all 3 trimesters were low birth weight and small for gestation age. And then one of the most significant complications of pregnancy, abruptio placentae, which puts both mother and infant at risk for morbidity and mortality. A significant reduction for first trimester use only, 9%, versus women who used all 3 trimesters, which was 15%. And so what you see here is that you can significantly improve outcome when you intervene early in pregnancy. Now, this article was published in 1989 in JAMA, the most widely read medical journal in the world. But people paid very little attention to it. Paid very little attention to the fact that even if a woman is using when she comes into prenatal care, the sooner we can get her off her drugs and alcohol, the better outcome for the pregnancy. The next really strong study that investigated treatment during pregnancy was the Kaiser Permanente system. And Kaiser Permanente has a program called Early Start, and they do a terrific job of screening all pregnant women for substance use and linking them into treatment which occurs within the context of primary care. Now, this study was published in 2008. They had 49,985 pregnant women, all of whom were screened with a screening instrument and urine toxicology. And they found that among this almost 50,000 member group of women, 17% were positive on either the screening instrument and or the urine toxicology. And they divided the women into 4 groups. Now, let me say again, this is not a randomized controlled study. You can't do those kinds of studies. But what they were able to do was to identify large groups of women who went through a graduated system of intervention. First of all, there were women who were screened, got a full assessment, and then received treatment within the prenatal care system. 2,073 of those women. Secondly, there were women who were screened and assessed, but received no treatment. 1,200 women. And there was a small, relatively small group of women, 156, who had a screen only. And then finally, there were controls, those women who screened negative. So the first 3 groups, the screening, assessment, treatment, the screening assessment, and the screen, all had positive urine toxicologies and or screenings for substance use. The controls, 46,000 of them, had negative screening and negative urine toxicology. And what did they find? Almost the exact same thing we did in our much smaller study from 1989. There was a significant reduction in the incidence of low birth weight, that is, born less than 2,500 grams, whereas women who got no treatment had a low birth weight rate of 12.1%. Women who had substance abuse screening and assessment also had an elevated rate compared to controls of 8%. But women who got screening, assessment, and treatment through the prenatal care services did not differ in their rate of low birth weight as compared to the controls. This same pattern exactly is seen in prematurity. That is, babies born less than 37 weeks gestation. And so babies whose mothers received treatment within the Kaiser system of prenatal care, their rates of prematurity were no higher than the control group. And finally, a very important measure, those babies who were born very premature, that is less than 33 weeks gestation. And what you see, the mothers who received treatment, their rates of having a premature infant less than 33 weeks gestation were no higher than the drug-free control group. Whereas if the women got only the screening and assessment, or got screening, assessment, and got screening only but no assessment and treatment, their rates were significantly higher for having babies that were very premature. Interestingly, just screening and assessment did have an impact in that the rate of very premature babies being born was significantly lower in the screening and assessment group than it was in the screening group. So even this points in the direction that assessment in some way serves as a brief intervention. In an accompanying article in that 2008 journal, there was an analysis of the financial impact. And so I'm just going to talk about one aspect of it to demonstrate. There was a 6% decrease in preterm delivery before 33 weeks gestation. So just to be clear, let me go back to the previous slide. If you look at the difference between women who had screening, assessment, and treatment, their rate of having a baby less than 33 weeks gestation was about 1.8%. But women who had screening only but got no assessment and treatment, their rate of having a baby very prematurely was 7.8%. So if you subtract 7.8 minus 1.8, you get about a 6-point differential. So what this says is by treating 100 women with screening, assessment, and treatment, you get 6 less babies born before 33 weeks gestation. Now, the average cost of caring for a preemie who's less than 33 weeks is about $50,000 to $250,000 per infant. Now, they also calculated the average cost of the whole screening, assessment, treatment intervention within the prenatal care system. It was calculated to be $500 per woman. So for 100 women, the cost would have been $50,000. Now let's take the minimum. If we say that the average cost of caring for preemies is about $50,000, you multiply that by 6, $300,000, minus the $50,000 cost, what you get is that for every 100 women, you're minimally saving $250,000. Now, if we go to the higher range, that is a cost of $250,000 for a preemie who's born before 33 weeks gestation, and this actually is more usually the case than not. These babies, of course, are very expensive. You multiply that by the 6 percentage points decrease in rates of preterm delivery before 33 weeks gestation, and you get $1,500,000 minus the $50,000 that you saved, the $50,000 you spent on delivering screening, assessment, treatment services to the 100 women. And what you come out with was $1.45 million in savings for every 100 women. So what I'm trying to demonstrate here is that prevention, early intervention, treatment during pregnancy saves lives and it saves money. But here's the reality. Most programs around the country don't have systems available to them in which they can actually incorporate treatment into prenatal care. And they don't have adequate treatment capabilities out in the community for pregnant women. So what are we to do? And this is when the idea of SBIRT comes in: screening, brief intervention, referral, and treatment. And this is what our work has been based in as we've developed screening strategies for communities. So what is successful screening? As shown in the Kaiser study, successful screening is only a first step in the process of identifying women at risk, assessing them, and referring them to appropriate treatment. And any screening effort, you want to over-identify women at risk. You don't want to just find those women who are alcoholics, those women who are using drugs on a daily basis. You want to identify all women at risk, and this is based in our previous message: no amount of alcohol, no amount of drugs is safe to use during pregnancy. And for screening to be successful in the primary care setting, it has to be fast, it has to be simple, and it has to be efficient. Ethical screening also requires that the screening process is scientifically sound, clinically appropriate, and is part of a larger therapeutic plan rather than for non-therapeutic reasons. Now, I ask you to think back to our 4 principles of ethical practice that we started with, and you can see that this is an important component. Therapeutic intent. Is the intent of screening, in this case, to access treatment for the woman, or is the intent of screening to identify those women who need to be referred to child welfare services? This has been the basis of our work in developing the 4Ps Plus, the screening instrument that many of your communities are using. Now, I'm not going to go into the 4Ps Plus because I think most of you are familiar with that. But I want to talk about our experience in, for example, one county we've worked with for over 10 years now, San Bernardino County. Now, after working with San Bernardino for about 2 years at the time, we wanted to do a preliminary study of just what impact our screening and brief intervention strategies was having. And again, for those of you that have worked with us, you know the brief intervention we developed and that we use is called I Am Concerned. It's a multidimensional intervention, and it's based on educational research that shows the importance of multisensory input when you are talking and trying to educate someone. So we did a preliminary study among 42 women who had a positive screen on the 4Ps Plus at their first prenatal visit. We did a brief intervention and then did a full follow-up assessment in the 3rd trimester. And we found that through this simple SBIRT process, screening, brief intervention, and when necessary, referral to treatment, 69% of the women were drug and alcohol free in the 3rd trimester, which is an extraordinarily high rate. We then did a larger study. Now, San Bernardino County is very convenient for this kind of study because it is the largest county in the United States geographically. It stretches from the Pacific Ocean to the Arizona border. And because we were working to roll out the 4Ps Plus screening across the county, we started in one corner of the county and worked across. So after about 3 years, we had 8,520 women who had been screened by providers who were using the 4Ps Plus and following them up with brief interventions and referral to treatment. And we were able to compare them to 23,000 women who had received prenatal care from providers who were not doing the 4Ps Plus. And when we looked at clinical impact, we looked at several parameters, but I think one that illustrates the outcome quite well is changes in low birth weight rates. And what we found was that look at the yellow first. In San Bernardino County overall, over the 3 years that we followed this, the rate of low birth weight went down 5%. Now, when you get more specific and compare those users of the 4Ps Plus with the non-users, women whose physicians were not using the 4Ps Plus, their rate of low birth weight went up about 1.5%. Whereas women whose physicians were using the 4Ps Plus, the rate of low birth weight went down 18%. And this was the first hint back in the days that we were doing the earliest research with the 4Ps Plus and I am concerned brief intervention. This was our earliest indication that we were really onto something. And as we have continued these kinds of studies, county by county, state by state, we get consistent findings like this. Now let's use this experience in San Bernardino County because the Board of Supervisors who were helping fund and continue to help fund this intervention, the Board of Supervisors says, well, so what? So what if you're improving pregnancy outcomes? What's the cost? And so in San Bernardino County, the first step we did was we did timed studies. And I have to thank the maternal child adolescent health team in San Bernardino County for helping us do this, and especially the director at that time. And they did some time studies for us to calculate how long it takes to do the screening, the brief intervention across all the women. And they got the time, and then we calculated the cost, what they pay medical assistants and nurses per hour, so that we were able to calculate the cost across San Bernardino County of doing screening, brief intervention, and referral. And the cost was calculated at $1.69 per woman. So for 100 women, the cost would be $169. Based on the previous information and the data we were able to gather from across the county, if a woman who was using drugs and alcohol received a brief intervention, the rate of babies needing ventilation in the newborn period was 3.2 per 100 births. Whereas if a woman who was drug and alcohol using but did not receive a brief intervention, 4.5 per 100 births needed ventilation. So if you do the calculation, the simple subtraction, you see that for every 100 women who get a brief intervention, you prevent 1.3 babies from needing ventilation. You can calculate the cost savings. Now, at the time, ventilation costs averaged $50,000 a day, and the average length of time on a ventilator for a newborn was 5 days. Now, of course, this has changed in the ensuing years because costs are much greater now for ventilation than they were when we did this initial study. But at the time, using this information, we found that the average cost of neonatal ventilation was about $250,000 per baby. So, if we had 1.3 fewer babies needing ventilation at $250,000 per baby, just for 100 babies, by doing screening, brief intervention, we were able to save the county $325,000 per 100 babies born. Now, all the Board of Supervisors needed to do then was multiply the 100 babies by the number of babies actually born in the county every year, and they found by a simple SBIRT system that cost about $1.69 per woman, they could save millions of dollars per year in costs for ventilation alone. Again, you're saving lives and saving money. So based on this information and a variety of other studies that were then being done, ACOG made some specific recommendations in their ethics statement. They said all physicians should learn established techniques for rapid, effective screening, intervention, and referral. They should practice universal screening with brief intervention and referral to treatment. They should treat patients with a substance abuse problem with dignity and respect, and all the while protecting confidentiality. So what our prevention efforts so far have focused on the preconceptional and the prenatal period. But what are our prevention touch points for children? What we've shown now is by intervening in the prenatal period, we significantly reduce the rates of prematurity, low birth weight, infant morbidity and mortality, neurobehavioral difficulties, anencephaly, and intellectual disabilities. I've discussed all of this today. Let me just mention in a previous webinar we did on marijuana use during pregnancy, we showed the published data on if a woman is using marijuana in the first month after conception, there's a significantly increased rate of anencephaly, which is when a baby is born with no forebrain. So I would refer you back to that webinar or the article we just recently published on marijuana use during pregnancy. The other of note here is intellectual disabilities. There are several studies now that show that if you identify the alcohol-using woman and get her off alcohol by third trimester, you significantly decrease the rate of intellectual disabilities in children whose mothers use alcohol during pregnancy. And again, that's something that we have discussed on previous webinars as well as in our various publications. But the other point I want to remind you about is that even if you don't identify the pregnant woman, if you can identify the infant who has been prenatally exposed, intervention for that infant is prevention. And why is intervention for the child who is prenatally alcohol and drug exposed, why is intervention so difficult? We get what we call the complex child, starting with the blue gear in the left-hand side of your screen. Prenatal substance exposure causes structural and physiologic changes in the developing fetal brain. We also know that early trauma can produce physiologic changes in the early childhood brain. And you bring these two factors together, you get the neurodevelopmental deficits in children with prenatal exposure, children who often also suffer early trauma, so that you get the neurodevelopmental deficits that again have been described in previous webinars. But here's what the research tells us. For substance-exposed infants, now these studies were done mainly with alcohol-exposed infants, but then if you look at the population, you realize, as I said before, even though the women were identified as primarily alcohol using, they were polydrug users. And the protective factors described by Streiskuth and her team back in 2004 showed that if a child is raised in a stable, nurturing home with protection from sexual or physical abuse and is recognized before the age of 6 years and received early intervention services, you can change the long-term developmental trajectory for that child. So the good news is, even if we don't identify the woman earliest in pregnancy, we can still have a positive impact on the child's outcome. Now, I've talked about this extensively in previous webinars and again in our publications, and so I'm not going to go into detail today on early intervention strategies for infants. But suffice it to say that what we have shown is you can build systems of care for children that positively affect their outcome. The tier 1 is universal screening and earliest intervention. And that consists of not only screening pregnant women, but screening all children. And the instrument we've talked about in the past is the Ages and Stages Questionnaire, the ASQ, and the ASQ Social Emotional. If you do universal screening with these children, plus your clinicians are aware of the non-developmental sequelae that affect behavior, especially the regulatory difficulties, you can eliminate 80% of children from your basket of risk. That leaves 20% of children that need further follow-up, and that's when we move to tier 2, early intervention. And in every state, by law, early intervention services are provided to children birth to 3 through IDEA, that is the Early Intervention 0 to 3 system, and for 3 to 5-year-olds through the schools, the pre-kindergarten special education interventions. So every community has these in place: 0 to 3 early intervention and 3 to 5-year-old school-based interventions. And by implementing fully tier 2 services, you're going to take care of another 10% of children. However, that leaves 10% that still need some type of further therapy, which is when you move into tier 3, focused therapy, such as attachment therapy for some children, specific physical therapy, occupational therapy at a higher level than what early intervention can provide. And that's 6 to 8% of children. And then you're left with the most costly children, the 2 to 4% of children in your community who need a comprehensive assessment and treatment through tier 4 services. And I've talked before in previous webinars about transdisciplinary assessment and treatment of children. So this is the system of care that can be developed, and we have worked with multiple communities across the country to develop these kinds of systems. So where does that leave us? That leaves us with proof that ethical interventions, ethical policies work. But here's the problem. We get into what I call the good enough syndrome. And I take this from the final chapter of my book, The Mystery of Risk. The good enough syndrome are policies that are declared good enough. And you've heard it before. Oh, we have early intervention in place. That's good enough. Good enough policies are policies that use the lowest common denominator of achievement to define success. Now, what are the characteristics of good enough policies? They're policies and practices that are developed in isolation from the community and from the target population. It's a very top-down effort in which you come in and say, okay, here's what we're going to do. And you tell physicians and other practitioners and the public what we're going to do, rather than get input from practitioners and the population. Good enough policies are reactive than proactive. Women are using drugs during pregnancy, take that baby away. And good enough policies are grounded in terms of financial rather than human cost. And this is ironic because, as I've shown you, good prevention saves lives and saves money. But the long-term financial benefits are often disregarded. And this is especially difficult when you work in communities and you say, we're going to spend more money in the healthcare system, and that's going to save money in the education system. And you have bureaucrats at the highest level that say, wait a minute, I'm spending my money in the healthcare system to save money for education? And what folks have to realize is that eventually it all comes out of the same pocketbook. Good enough policies and practices focus on singular diagnoses rather than co-occurring disorders. And this is especially a problem at the federal level when there's talk about, quote, high risk, end quote, populations. There's no such thing as a high risk population. We know that substance use and abuse occurs across all populations, not just certain racial, ethnic, or socioeconomic populations. But this is the inherent bias that you see in many federal and state policies. Good enough policies and practices determine service access based on eligibility rather than need. But what you get is access to services that are given to those children who will benefit the least, rather than those children who would be most amenable to early intervention. And then, because of financial pressures, you restrict the range, the intensity, and the duration of services. Good enough policies and practices define success in terms of broad quantitative measures geared to participation and contact rather than client-oriented outcomes. And I can't tell you how many times we've been called in to evaluate programs across the county or a state, and we're asked to determine success based on how many women were screened, how many children got screened, rather than looking at child and family outcomes. It's what we call a toll booth approach to evaluation. Good enough policies and practice are designed within systems rather than across systems, and allow service integration to substitute for systems integration. Service integration depends on people knowing people. So if Jeff is a primary care provider and finds a patient that needs treatment services, he calls Susan, who he knows runs a treatment program. But what if Jeff or Susan retire? What happens to that link? That's service integration. And through service integration, children and families fall through the cracks. However, through systems integration, you have policies and practice that provide an umbrella across all systems, so that there are policies and practices that guide care and prevent children and families from falling through the cracks. What are some examples of the good enough syndrome? And I've picked one of the easiest arenas to talk about this in, which is the child welfare system. So let's look at these. First of all, using the lowest common denominator for success and grounded in financial rather than human costs. Often placement decisions, the decisions to reunify families, are based on 2 out of 3 factors: good, fast, and cheap. Another area, defining success in terms of quantitative measures geared to participation and contact rather than child-oriented outcomes. And a good example of that is parenting classes. Oh, that mother finished 12 weeks, she graduated 12 weeks of parenting class, so she gets her baby back. And then no one can understand why that baby ends up in the ICU with shaken baby syndrome. Dependence on inadequate but easily classified criteria. And the best example of that is toxicology studies. Almost all states depend on urine toxicologies to identify children at risk from prenatal substance exposure. This is a perfectly false way to address the issue, but it's very convenient. And then finally, service access based on eligibility rather than need. And the early intervention system in all states is a good example of this, using developmental scores and defining false criteria such as needing a 30% deficit across 2 domains of development in order to be eligible for early intervention. Well, what about the child who has a 30% deficit in only one area? What happens to that child? So I bring you back to the ethics of prevention. And I hope I've given you examples of how these four basic principles apply to the work that all of us do. First of all, therapeutic intent. For example, is the purpose of prenatal screening to report mothers to child welfare services, or is it to enhance access to services for the women and children? Secondly, do no harm. What about those policies that say if a woman has a positive urine toxicology, that child must be removed from her care? Because what impact does separation of the child from his or her mother have on early brain development? We know it does have an impact. Justice. Why do we allow continually to let racial and social biases drive our identification of high-risk populations? And finally, respect for autonomy. How do we balance the rights of parents to raise their child as they wish versus the obligation of the state to protect the child? Those are the four key questions that you have to think about. And now, I want to move from the ethics of prevention to the moral obligation of prevention. Because I can't give you a lecture on the moral obligation of prevention. That's a decision you have to make. It's a very personal decision that you have to make on your own. And I would bring you back to something I briefly referred to before. I call it the three-legged stool. If we're going to develop policy and practice, first and foremost, we want policies and practice to be good. We want to provide good services. But a three-legged stool with only one leg doesn't stand. And so we have to add fast. We want our services to be not only good, but to have an impact very quickly. We want to create change in our families' lives. But a two-legged stool won't stand either, because it takes a personal commitment. Good, fast, and cheap. How do we make services inexpensive, but at the same time good and fast? Because cheap services will be fast, but they won't be good. Good services will be fast, but they won't be cheap. And fast services may be cheap, but they won't be good. And that's why it takes a three-legged stool, and this is where your decision has to come in. We've talked about the ethics of prevention. Only you can answer the question about the moral obligation you have and your program has for prevention. And that is the answer to, is prevention a moral obligation? The answer lies within each of you. And that's the decision you have to make. So I hope I've raised more questions than answers in this webinar. Again, it's something I feel very personally about because we do have an obligation to the families that we serve. I hope that this has been a stimulating conversation for you and that you will think about the kinds of issues that we have raised today. I appreciate your joining us and look forward to our continuing work with you in our final webinar and in our webinar series for 2017.